Good morning, good afternoon, good evening from wherever you're joining us from. A very warm welcome to this session, Applying Behavioral Design for Health Equity, hosted by UNICEF. UNICEF is pleased to present this session and just to showcase some of the progress that we're making in applying behavioral science in our programming for children and their families' well-being. It'll be a very interesting 60 minutes, and we invite your active engagement and participation. And we do have presentations and discussions from our Europe and Central Africa regional office, and from Georgia country office. We also have our West and Central Africa regional office, and from Ghana country office. So a quick housekeeping, please let's use the Q&A function, the chat box, so that we're able to react to your questions and comments that you may have. So also excuse us if we have any tech glitches. We are coming to you from all across the globe. I'm in Iraq, Vincent is in New York, Ben is in Florence, Karen is in Ghana. We are coming from Florence and also Georgia. So thank you so much. And without wasting much time, let me call upon Vincent, who is our global lead for social and behavior change in UNICEF, to give us a quick update on our recent expansion from communication for development to social and behavior change. Over to you, Vincent.
Thank you, Ken. Good morning, good evening, good afternoon to everyone. I'll be quite quick, just a few words on the type of organizational context in which the amazing projects that you are about to hear about are happening. Earlier this year, we reframed, as Ken said, our functional area called Communication for Development into Social and Behavior Change. That was a corporate decision made by the Office of the Executive Director, which followed and concluded a 2-year process in which many contributors took a hard look at our business model and how we could further improve what we were doing in the C4D era. That led to a change that tackled in a fairly systematic fashion elements from operation, programming, strategy. And if you look at the new strategic plan, there's actually a fairly elevated position for social and behavior change, both as a key change strategy and as a series of results across all of the sectors. This shift builds on what C4D was doing. So we are reaffirming our commitment, our expertise to community engagement, to social science, to participation, to people-first approach. But we're also expanding by embracing behavioral science a bit further. And what that means practically is strengthening our evidence agenda, I think, from the analysis of behaviors all the way to the way we measure and track their change and how that links to our programs. And that also means opening to new programming territories outside of communication, which was our and still remains the core of what we do, more into the supply side of things. So looking more closely at policies, at services, at products, embracing, I would say, the complexity of what behaviors really are about. And they are very often driven by things that cut across any framework we want on the demand supply side or any divide that we want to put out. This is the type of context and effort that we've been working on for 2 years. And lastly, recently, the program group in which I work teamed up with the regions, the countries, the people you're going to hear about, and the Innocenti research team where Ben sits, to create our first behavioral science unit that you're going to hear from. And it's fairly critical because we have behavioral results in all of our goal areas, in health, in education, in social protection, in nutrition. We have social results across these sectors as well. And we have a significant potential for scale. As you know, UNICEF works in 190 countries. We have close to 500 staff who are social and behavior change staff. We invest hundreds of millions in this area of work. So I cannot stress enough how important that shift is for the organization. It's important corporately, but today what you want to hear about is the countries and the amazing people doing work on the ground. So that's it for me. I'll stay on the call, happy to answer any question if there is interest, but I hope the questions will be on the projects themselves. Back to you, Ken.
Thank you very much, Vincent. All right, so right now, let me call upon Ben Hickler, who is our behavioral science research manager based at our Inocenti office in Florence. Over to you, Ben.
Thanks so much, Ken, and thank you, Vincent, for setting the stage. As Ken said, I'm Ben Hickler at UNICEF's Office of Research in Inocenti, and I've been working for the last decade, I think, with Vincent and Ken and our panelists in this call, and our network of social and behavior change colleagues all around the world. As Vincent said, we're 500 plus strong, and in the last couple of years, we've really been trying to grapple with how to harness the power of behavioral science to, in service of our mission to secure rights and results for children. The topic of this webinar is behavioral design for health equity. So those are kind of big terms and definitely deserve some background and unpacking. Some of UNICEF's first pathfinding innovations or explorations in terms of applying behavioral science were in the fields of primary healthcare and immunization. At the time, there was this kind of growing recognition, I would say, that supply side interventions, capital investments in building health facilities or focusing on vaccine availability alone were insufficient. They weren't necessarily increasing primary health coverage and coverage of essential interventions to the most vulnerable, chronically underserved, least visible populations. So this was this real equity dimension. And we realized that in the end, evidence and experience showed us that you can't assume that if you build it, they will come. At the same time, we were running up against the limits of some kind of conventional wisdom or conventional approaches and ways of doing, where we focused a lot on informing people about the availability of services or informing people about disease risk or raising awareness about interventions or services. So this focus on information, education, and communication was only getting us so far when it came to expanding the coverage of primary health services. So this is really where behavioral science, the evidence and methods from the behavioral sciences came in. We knew that it was much more effective to align with existing norms and values and routines and habits, focus on things like reducing friction, making it easier, bringing the services to the people rather than trying to get the people to come to the services, using techniques to activate intentions to help people follow through on their intentions to achieve results, rather than trying to change what people think and feel. You know, the focusing on changing hearts and minds or informing and educating were not enough. So this was a great driver in kind of shifting UNICEF's approach to health equity. But there were limits also to some of the direct applications of behavioral science and the way that we were approaching it at UNICEF in these initial days. There was a lot of focus on solutions, so behaviorally informed solutions like nudges, reminders. We knew that there was a lot of potential. We knew there was potential power in applying these kinds of tactics or techniques, but we also knew that we had to make sure that we didn't let the solution drive our work, that we needed to have a problem first approach. So we needed to let the problems define what tools we needed, and we shouldn't let the existence of new tools or our awareness of new tools over-determine our approach to solving complex problems. So for this reason, we spent a lot of time focusing on incorporating behavioral science in sort of principles and a kind of lens, socializing some of the lessons from applied behavioral science and behavioral insights approaches globally, taking them from their Western educated, industrialized, rich democracy kind of origins and seeing what might work in the kinds of contexts that UNICEF works in, which are quite varied and tend to be in low and middle income countries. We work in both development and humanitarian settings. So this I think was rather transformative. And this is where we've kind of developed a merger between behavioral insights as an approach and applied behavioral science and human-centered design. There were aspects of both of these approaches which are sometimes presented in opposition or in distinction, but we knew that it was a powerful combination. I think we had a lot of success early on. If behavioral design is characterized by define, diagnose, design, and test, I think the 3Ds, we didn't struggle quite as much in terms of applying these principles and a lens coming from the evidence from the behavioral sciences to our definition of problems, defining which behaviors to focus on, diagnosing the drivers, and designing potential solutions. But now we really need to focus on experimental methods, quasi-experimental methods, and other approaches to try to get a better sense, ideally through randomized controlled trials or other forms of quantified evaluation, what's working. So for these reasons, we've established this Behavioral Insights Research and Design Laboratory, which is a collaboration internally at UNICEF, working from two different ends. One end is really trying to socialize and cultivate a culture that's grounded in evidence and methods from the behavioral sciences. And the other is in establishing partnerships, creating training materials and other sort of technical materials to upskill our labor force, if you will, and make sure that folks that are looking to apply these kinds of powerful approaches have the resources internally and the partnerships externally to make it happen. So that all said, as Vincent, indicated, UNICEF is a decentralized and very diverse organization. It's not a command and control organization. And honestly, this kind of approach won't work in a plug and play manner. So just like a lot of behavioral science doesn't work, you can't just copy and paste an intervention from one context and expect it to work in another. We've needed to really take a differentiated and tailored approach to scaling up the application of behavioral science in our work. So that's why this is so exciting, because we have two different regions represented. We have two really interesting country projects to illustrate some of the ways that we've approached health equity challenges. We have now 15 plus active projects in 2022. So these are just a couple illustrative examples. Yeah, the interesting stuff is coming from our countries and our regions. And I think one of the nice things that this will illustrate is just how this differentiated, kind of tailored approach to applying behavioral science is working at UNICEF. So I'll stop there and stand by and hand it back to you, Ken.
All right. Thank you very much, Ben, for giving us an introduction and an overview of how UNICEF is applying behavioral design for health equity. So right now, let me hand over to Karen Greiner, who is our regional advisor for social behavior change for West and Central Africa. Karen, over to you.
Hi, thanks, Ken, and good afternoon, everyone. I want to start with the way we start our meetings normally, which is hello, bonjour, bom dia, et buenos dias. We're in a region with 24 countries with 4 languages. But to get beyond the imported languages, I could probably start by teaching you a few words. I have a feeling you've been dying to know how to say easy in Hausa. You ready? Mai sauki. And to say make it easy, it's asaukaka musu. So for us, equity at UNICEF, if we really want to talk about reaching the underserved, we have to think about our partners. And not all of our partners speak French and English and Spanish and Portuguese. They speak Hausa and Kanuri. They speak Lingala and Swahili. So it's been really fun for us to get a bunch of partners and a bunch of resources and try and decomplicate things and try and make it, get the bite-sized version. We have a feeling that people aren't going to watch the 5-hour webinar if they haven't seen the first bite-sized piece that seems easy and attractive to them and timely. So we love frameworks. I'm citing the EAST framework, We've converted it to French, FASO, facile, attrayant, social, opportun, and we've converted it now to Hausa. We like pocket guides, we like cards, we like anything that's simple. We've had a lot of great partnerships because we've recognized that all of the useful things that have been produced by behavioral scientists and universities, they're only used if they are both useful and usable. So part of our task has to render what's useful more usable. So as I mentioned, we love the cards, we love the bite-sized pieces. We've been fortunate to have a lot of great partners. I mentioned that, we have a course online that's open free to everybody that we partnered with Duke University, that our team in New York put together. We have partnerships with Nudge Lebanon. I'm holding these cards in addition to the East framework. We have the shape difference framework, and they've been nice enough to translate that into French. And I've hand carried this personally to many countries in the region. We've been working with the Behavioral Insights team and Anastasia, my colleague from Ghana, will talk more about that. Also with Nucleus Group and Common Thread. This is not an advertisement for these organizations. It's just to tell you just exactly how, I want to say, entrepreneurial we've had to be to find the right partners. I was in Maiduguri a couple of weeks ago, and our colleagues are going very deep with human-centered design, together with some support from Nucleus Group and a little bit of behavioral science. My colleague Anastasia has a master's degree in behavioral science, so she's been able to do a lot of behavioral science and human-centered design, and she'll talk to you about behavioral design for health equity. Whereas our colleagues in Burkina Faso are starting with just a little bit of behavioral science. So we're at the concept level. So our region, I'd say we go everywhere from nothing at all because people simply aren't ready, or we haven't figured out how to say nudge in Kanuri yet, or they're just busy doing entertainment, education, soap operas, and very happily doing so, to concepts, to very deep partnerships and elaborate projects, which we hope will be measured in the near future. I'm going to pass it over to Anastasia, who has more interesting things to say because she's the one doing the work together with her colleagues and together with the Ghanaian government. So over to you, Anastasia, and thank you very much.
Thank you, Karen. Thank you, colleagues. So I'm talking to you from Ghana, and this is an example of actually quite successful intervention that was pretty much liked by all stakeholders, and I think this is the most important. And it was a nice also example of productive collaboration, which is not always the case between regional office, country office, creative minds of Common Thread, and our government and civil society partners, because they were quite involved in the process, and it also ensured its effectiveness. So the beginning of the story starts with this actually image. So this is the photo from one of our vaccination field monitoring in Ghana. And once I saw this, and some of my colleagues also shared the similar images from different parts of Ghana, it seems this kind of communication can not only increase vaccine hesitancy and distrust in health services, and also lead to actually impacting much longer relations between government and communities. And this is the example that actually inspired us to explore human-centered design. I immediately contacted regional office and said that this is the situation currently. Can we think about wayfinding system? And we ended up on brainstorming and actually designing this project. So the situation in Ghana with COVID vaccination is the following. We were the first country in the world to receive COVID vaccines as part of COVAX facility. So one would say we are lucky and we are incredibly grateful. However, it also increased the level of hesitancy much higher than in any other country, because there was a suspicion, why Ghana, why the first country in Africa? And there were also quite a lot of barriers related to logistics. So the delivery was not possible to predict. The target populations would always change. There would be shortages, or there will be too many vaccines. So in terms of managing the demand, it was difficult. And as of now, we have approximately 30% of fully vaccinated, 40% partly vaccinated. And among the remaining targeted population, at least 60% say that they will unlikely take the vaccines. But why? What are the barriers? Are these all people that are hesitant, negative about vaccines? So there are other reasons. In our case, we see that at least 40% say that they think it's difficult to get. So it refers to the point of this quite difficult and unpredictable delivery mode of vaccines. So people actually confused, they don't know. Some, of course, is related to quite spread misinformation, sometimes distrust to health services, and so on, so on. So the problem that we took as an aim is try to actually target the people that from one side opportunistic. So yes, they are quite positive about vaccination, or they're neutral, but they just want to get it easy. So that if we provide them with this opportunity, it would be fine. But I think with human-centered design, we not only make process easy or follow the EASE framework, and we make signs timely in the vaccination points, they are quite clear, simple. We also increase the trust, because if the communication is high quality and it's tested, we are pretty sure how it will work. But the communication, as I showed you at the first image, or now, or the poor communication or not relevant communication, can lead actually quite longer term negative effects to the trust between communities and government, because communities do expect high quality service from government. So our problem was to address some of the biases and barriers through a human-centered design intervention. And as I said, there was overload of information. It was not consistent, conflicting, as well as overload of misinformation, a lot of rumors, and some mistrust, yes, in government and health services, and perceived risk. Of course, people start to not see clearly what are their challenges or risk from COVID. President made address that lifting all prevention protocols. So we are dealing with some behavior barriers in the following way. When we speak about conflicting information, we developed a prototype that was quite actually clear on who is the target audience. Even on the image, we try to illustrate it's a pregnant woman. We said clearly what are the target groups. We address the issue of trust with making the mural look like a health service branded item. And we know that there is a trust to health service, or Ghana health service. There may be some mistrust to, on the community levels to health workers, etc. So we branded it as an institution, and trust in institution in Ghana is quite high. And of course, we made try to incentivize people. So we said it's free. We said there are working hours, and it's long. It's just walk in. So we targeted all these behavior barriers through our prototype, and pre-tested it. This is important to know that this is just a pre-testing information. From one side, it's really what is really practical exercise. We develop simple guides, civil society organizations in different locations. We are asking communities following the guide to see the insights. And most of the comments were positive. People understood, they felt relevant. They said the intention to vaccinate would be positive. However, the useful comments were actually about images and how to localize and contextualize the images. But this is not evidence on the impact of the intervention. We will compare the admin data on vaccination coverage in the points before we installed murals and after. And through this, we will see the impact. But again, we are only in the process, and you are one of the first seeing these murals now. So the lesson learned is that the human-centered design potentially, and behavior design, as I would say now, is a potentially very effective intervention as for Ghana context due to literacy rates, diversity of languages, and also the environment itself. So we want to explore this tool more. We started hand washing intervention. We'll follow with some other intervention. We think that it's of course important, we were so creative with our colleagues on different solutions, but to fit to the environment where sometimes you would not have walls, or there will be other, constraints and resources. So we think that from one side, human-centered design is easy. You come to the community, you just draw or use your materials, but we need to be careful when we design this solution. The solution should make any local community to be able to do it by itself. And that's, I think, a beauty, but also some, kind of limitation. And yes, we will look further to the impact analysis to show to see the evidence, how it worked actually in comparison with what we tested and we predicted. And that's actually what is now happening in Ghana. Hundreds and hundreds of these murals are drawn or placed in different locations where the vaccination takes place. So thank you so much, colleagues. I will follow on questions in the chat.
All right, thanks so much, Anna and Karen. So yeah, please keep the questions coming in the Q&A section. We will get back to them after we hear from our Europe and Central Asia regional office from Georgia. So let me invite Sergio from our ICARO office. Sergio, please.
Yeah, thank you, Ben. Hi, everyone. Good morning, good afternoon. I'm Sergio Tomsha. I'm the Social and Behavior Change Specialist with UNICEF Regional Office in Europe and Central Asia. And I'm happy to be here with you today and to share our experience in how we are strengthening and expanding the application of BI and behavioral science in Europe and Central Asia region in the area of health, but also beyond. As was already mentioned by Ben and Vincent, UNICEF is strengthening its social and behavior change work to ensure that people are at the center of what we do and to apply in a more systematic manner social and behavior evidence to support this positive change in the lives of children, the families, and communities. Within the regional office in Europe and Central Asia, we have recently initiated the process of establishing or setting up a BI unit. And the purpose of this unit is to really help make the policies, the systems, the services in the countries that we are supporting in this region become more relevant and more responsive to people's needs. In this region, we do operate in the context of high and middle income countries, which do have relatively strong institutions. And there is an increasing demand for rigorous evidence of program effectiveness. That means for us that through BI interventions, we can support small tweaks in policies and systems to influence uptake of services, for example, or adoption of positive practices by people and communities. At the same time, setting up the BI unit within the regional office can help us leverage and build on several opportunities. First, it will help us increase the understanding and visibility of BI, not only within UNICEF and within UNICEF country offices, we have 22 of these in this region, but also among national stakeholders. It will also help generate over time demand for BI within the countries. Through a strengthened BI expertise in-house within the regional office, we will also be able or better positioned to provide stronger and more flexible support to countries to address various challenges in the area of health and beyond. And finally, we do believe that through a proper assessment and documentation of BI work that we are supporting in the region and outside of the region as well, we will help the knowledge sharing on behavioral insights within and outside the organization. Through this BI unit, we will also be better positioned to provide countries with support, over the whole project cycle, from the conceptualization, development, implementation, and evaluation of the BI interventions, and at the same time building national capacities in this area. And again, I believe we have a strong foundation to advance in this direction, as over the past years, we have supported a number of BI interventions in this region. For example, in Kyrgyzstan, we have examined behavioral determinants influencing adoption of COVID-19 protective measures, and we tested approaches to prevent misinformation spread on COVID-19 around social media, which helped UNICEF and national counterparts inform the response and adapt the response. In Georgia, North Macedonia, Bosnia-Herzegovina, Kyrgyzstan, Montenegro, and Uzbekistan, we are engaging in identifying, testing, and implementing BI solutions to increase demand for routine immunization. And you will hear more, one example from Georgia. In Montenegro, we are engaging with the national stakeholders to explore BI solutions to influence the spending of child allowance by caregivers, by families, to support early childhood development outcomes. And finally, in the context of Ukraine war, HCD approaches are being applied across several countries hosting refugees, engaging with these refugees, with the families, with children, to help define and design the services, the tools, the messages which are being developed in these countries. So all of this work is done in strong collaboration with the national government institutions to ensure that the local ownership and accountability over the achieved results, and ultimately the institutionalization of these final solutions. The solutions are identified with active participation of the local communities using the HCD approaches, And of course, they will be assessed and evaluated before they are recommended for scale up. So I will stop here, Ben, and I will like to hand it over to Nino, my colleague, who will have a short presentation sharing with you the example of Georgia, how we have used behavioral insights and human-centered design approaches to design solutions for HPV vaccine uptake. Nino, over to you. You're on mute. Still on mute.
You're on mute, Nino, please.
Thank you. I truly apologize. Hello, everybody. My name is Nino. I'm a social and behavior change officer working with UNICEF Georgia, and I have a privilege to present the journey which we have started last year related to the behaviorally informed programming mainstreaming with our programmatic cycle. So first of all, let me emphasize that applying behaviorally informed programming into is relatively new in my country in terms of international development partners and health-related projects. And UNICEF, through the support of our regional office, in fact, served as a pioneer in the health sector to introduce it. The issue we were facing and we are facing relates to the very low coverage of HPV vaccination in the country, which is about 11% according to the WHO estimate, and it's relatively higher according to the national statistics. However, this is within the context when the vaccine is available widely for the girls of respective age at all primary healthcare facilities across the country, free of charge. Through the support of our regional office and BI team, we initiated the very small intervention last year, which was targeting to apply behavioral science to improve coverage of the HPV vaccine within the country. And all has started from the exploring phase where we have carried out the extensive desk research to derive the data and come up with the major behavioral bias and bias which was related to the low intake of the HPV vaccine. And this was, it has to be mentioned from the very beginning that the intervention was fully human-centered, and it involved the multidisciplinary stakeholders, starting with the caregivers, continued with the high-level governmental officials and healthcare providers. And we have organized a solution iteration workshop where we have discussed the cognitive and behavioral bias and background problems that hamper the uptake of the HPV vaccine. So the present slide indicates the main issues articulated within the workshop, and importantly, that workshop enabled us to work with the different groups and filter the three major barriers to focus on. The first one, that the people are not getting reminders, caregivers do not receive reminders, and simply they are unaware of the fact that vaccine is available. They are unsure of risks and benefits and unaware of risks and benefits. And even the doctors are poorly informed about the worth and significance of the HPV vaccination. The core was that the barriers were filtered based on in order to find the solutions and agree on the implementation strategies. We have filtered the barriers based on the three major filters. The first one was whether the barrier is behavioral and it can be solved through the behavioral intervention. The second was, does the barrier impact a large number of people? And third one, is there an existing touch point so we can influence and overcome this barrier? So there were the several good solutions introduced and found. However, the workshop participants, multidisciplinary participants of the workshop have agreed on the two shortlisted interventions. The first one was the communication that goes to from the health system or doctors to the caregivers on the HPV vaccination. And the second one was the reminder on the HPV vaccination. Having said that, the prototype behaviorally informed solutions were developed, and you can see on the screen the prototype message that have undergone the 3 levels of testing. Then these reminders were sent from the selected health facilities to the caregivers of the girls of the respective age. And very important finding was that within 4 weeks, 78% of the caregivers who received the SMS reminders went back to vaccinate their child. So in fact, this is the success story when the very small-scale project, by applying behavioral science and human-centered approach, turned to a large-scale intervention, because the government of Georgia and health authorities have committed and made a decision to mainstream these solutions within the electronic health system. And starting October this year, the entire cohort of the targeted age group, parents of the girls, will receive the SMS reminders calling them to go and vaccinate their girls. This is the part of the state program, and a specific memorandum of understanding was signed by UNICEF and the Ministry of Health and National Center for Disease Control and Public Health to precede the process with the randomized control trial to assess the effectiveness of the several SMS messages to agree on the one to be shared with the wider public. So in other words, in July, we are initiating the randomized control trial with 5 arms, which includes 4 intervention groups and 1 control group. And the sample size is 50,000. And through the support of our regional office and international partners, we'll analyze the data, and in 60 days, we'll see which messages work better. So in any case, this system of the SMS reminder will be launched, and it will become a part of the state program. So evaluation design is presented on the slides, which I have articulated already. And I spoke already about the national scale up. However, please note that beyond this intervention, we are working with the health providers across the country to articulate and build their skills on vaccination, particularly related to the HPV vaccine, and it is being carried out through the different groups of professionals, including the association, Union of Professional Association, Association of Nurses, and young volunteers. So over, and I'm ready to respond to any questions as they develop. Thank you.
Thank you very much, Nino and Sergio. So now it's time to attend to some of the questions that were posted, but please also keep posting your questions in the Q&A section. So we do have a question from Paula. I'll just read it out. Could you talk a bit more about how, as an organization, you have blended best practices, behavioral science and design science? Have you done this via tools, education, a commitment to learning, etc.? I think a lot of organizations are interested in doing this, but don't know where to start. Let me call upon Karen Greiner to address this question. Over to you, Karen.
Yeah, thanks, Ken. And I'll maybe pass it over to Anastasia after, because through partnerships is one of the ways that we've been blending, but through tools as well. And to be totally honest, it's happening quite organically, and it really depends on the capacity and the interest and the motivation of the countries. So we're seeing, as we present a lot of approaches that go beyond communication, some people, we have a social behavior change series where we do different levels. And first we introduce 3 approaches, then we add 2 more. And we're finding some people are gravitating naturally towards things like co-creation, rapid prototyping, and so they want to go deep with human-centered design. Other people are interested in making things, as I said, making things easy for people, because we're not getting into very elaborate behavioral science at this point. But we've already had colleagues in Niger saying, oh, what if we vaccinated at 6 a.m. to 6 p.m. instead of only 9 to 3 p.m.? So people are already asking great questions. So things are happening organically as we introduce the different approaches. We say it's like we're stocking the cupboard, and it's up to them to sort of pull the ingredients that go well with their context and with their capacity. When you have someone like Anastasia in Ghana, who has this deep training in behavioral science, I think through partnerships, Anastasia, is how the blending has happened. Let me pass it back to you, because sometimes you're doing more human-centered design, sometimes you're doing what we're calling behavioral design, blending the two, and other times you've been doing straight up behavioral science through some of the measurement work you've been doing, which we didn't talk about today. But how does the mix happen at the Ghana level? Over.
For us, human-centered design is a tool which we actually use after doing quite a rigorous behavior drivers analysis. So, you know, behavior science is mostly about research, yes. Then, okay, you do experimentation, etc., but the core of this is research. And behavior design, I think what it lacks a little bit, I mean, if we are honest, yes, it's also a new concept, let's be critical to it as well. It does lack a little bit of research part. It's very focused on user testing, you know, usability, etc. But I mean, behavior science gives us pure data. So what we do usually, we start the same research, and then we use this research to see which interventions will work better. You know, will it be behavior science intervention? Will it be more changing the environment? Will it be maybe even we can go to policy level, because some research shows that, okay, the problem is not the service demand. It's clearly more and more about service itself. And then, you know, after the training, of course, it's all about making sure that in any contract, there will be some kind of co-creation. Without this, there is no ownership and nothing can be relevant, especially human-centered design, the core, as I said, you know, even a small change in the illustration of the mural made a difference. Community will look at this and trust and think, oh, this is something from us. Or they will just go pass by and think that this is again some advertisement. So I think making it relevant through co-creation ensures that then it stays. So communities, they were drawing it, they were pre-testing it, then they were actually so they were creating, pre-testing, and then now they're drawing. So that's actually ensures that the tool stays and they will use it more just after 2 days training we do, Thanks.
Thank you so much, Anna and Karen. So while you still have the floor, there was an earlier question which I think relates to the Ghana presentation from Soro. He or she asked, how did you do the interview task? So would you quickly answer that, Karen?
I'm going to give this one to Anastasia because I believe it's talking to the interviews done in the context of the prototyping. Over.
Yeah, it's the first time I saw real testing in my 20 years of work in communication and social behavior change, to be honest. So the real testing, not like, something what we report as we tested. So the civil society organization, they received the quite easy, and it was a fight to make, meet the realistic testing and something what agency thinks can be realistic. Quite an easy field level guide, 1 page of questions, which all civil society organizations went to different parts. They put the big mural prototype on the wall and they were asking target communities, people that we are interested in seeing. And they were rating each of the points, how we want to see this mural, is it understandable? Is it relevant? Do they feel trust? What action they will take? So they were interviewing. So it was done just on the streets, on the most busiest streets across different cities in Ghana and different locations. They interviewed, they put it in Google Doc, we received the data. We got also some, they were recording some comments because there were some open-ended questions, which is important for people to express themselves. And yes, then we analyzed and we changed quite considerably. I think next time I should show how we started. So what was the first idea of mural? It was different to how we ended up after the pre-testing to make it relevant, again, to the local context.
All right, thanks, Anna. So we'll move to the next question from Ananya. The question reads, my question is, other than using murals to direct citizens for vaccination or social norms to increase uptake, what other insights or interventions can be used for this purpose? I come from India and the population here, as known, is one of the largest and the most diverse in terms of age, socioeconomic status, gender, and so on. How can one go on to use behavioral science insights in extremely diverse scenarios? So I'll give this to Vincent and Ben.
Thanks, Ken, and thanks for the, Ben came on screen first. Does that mean Ben? Oh, I'm here there. Okay, I'll keep the floor, Ben. Thanks for the question. That's a big question. And I'm gonna try and give an accurate answer. The reality is that the issues that you're pointing to stem from longer term, more systemic problems in the health sectors, which also have longer term, more systemic solutions. Broadly speaking, I see these solutions around strengthening community participation in primary healthcare, strengthening the social and behavioral data agenda in the health system, and strengthening and institutionalizing the community health workforce. To make it more concrete, taking the example of community participation, we're trying to promote as much as we can the involvement of communities, users, peoples, leaders in planning the health service, in setting the priorities of the health service, in designing the nature of the service, in pushing for some social accountability to improve the service. And that needs to happen all the way from the policy level down to the health facilities in the districts where the people live. The issues we face regularly with trust, with cultural appropriateness, with do we meet the needs of the people, are issues that should be dealt with in a prevention manner, not in a responsive manner. So when we are being asked to build demand or to comply with policies, there's a fundamental problem, in my opinion, that obviously you have a harder time building demand if the services have not built with the people in the first place. You have a harder time helping people comply with policies if the policies don't match their daily realities. And we've seen a lot of that with the COVID pandemic health measures and response. But that's a systemic issue across the health system. I could say the same about what I said about community health workers, looking closely at how they're selected, how they're trained, how they're supervised, how they're paid. All of that matters a lot. So the answer to your question is, it's systemic, but there are systemic solutions. These solutions are also people-centered, such as behavioral science. And I think it helps illustrate the point that for us, behavioral science and these applied behavioral approaches are also one of the tools in the box, and we have to use a vast diversity of approaches and tools to succeed in what we do in social and behavior change. We're gladly adding what we just discussed today to what we were doing before, but no magic bullet. And yeah, it's a fairly complex matter. Ben?
Yep. No, thanks, Vincent. I think you said it all, and you said it well. It just reinforces something that I kind of tried to get across at the beginning, and I think that Paula's question also raises it. One of the most important things that we need to do is spend time on getting the problem right. Defining the problem correctly is the key first step versus jumping right to the evidence about solutions that have worked in a different context and then seeing if you can apply it in your context. So spending the time to really make sure that we are addressing the right issues. So if it's those deep systemic entrenched issues, we need to come up with long-term, deep and systemic sets of solutions. And it is tempting, and I think it's a risk in the applied behavioral science space to jump to simple tactics and simple techniques that have worked in one place and see if you can slot them in elsewhere. And we need to resist any easy solution. We could call it bike shedding if you want to give it a behavioral science term, or Parkinson's law of triviality. You're substituting a simple problem with a simple solution for something that's much more complicated. So spending that time on getting the problem right and clearly defined takes us a long way towards solving it with appropriate means. Over.
All right, thanks, Ben. So on, Ben, we move to the next question. It's in the chat. How do you see the effect of not being aware of HPV side effect as barrier communication on side effect of HPV? Sergio and Nino, would you like to tackle this one?
Yes, thank you very much. Actually, from this program perspective, when everything, whatever is new, and especially when it related to the health field and vaccine, is scaring people. So the HPV vaccine is relatively new again, and lots of questions among the community are rising, and not only within the community, but within the general practitioners as well. So this is why when within the project the caregiver receives the SMS message, it has the special link through which the person is connected with the site of the National Center for Disease Control and Public Health to see all the details related to the vaccine, including its side effects. From the different perspective, UNICEF supports the government of Georgia and the Ministry of Health in building capacity of the health system and health practitioners, particularly the primary healthcare providers, pediatricians, and nurses, in enhancing their knowledge or reviving their knowledge related to the vaccines, including HPV vaccine. So that's my response.
Thanks so much, Nino. Sergio, do you have any? Okay, please go ahead.
Yes, and I would like to maybe connect it with another question that was in the Q&A section, the thoughts on increasing risk perception, because I see some similarities. And Ben already answered that, it depends. In some cases that can work, but actually in many cases that is not the answer. Because the real question is the risk perception the key factor that makes people behave in a certain way or not? And just to give a couple of examples, and I see Lori is among the participants. We worked with her team in Kyrgyzstan when we were looking at the adherence to protective measures in the context of COVID-19. And when looking at behavioral determinants, we have identified that the individual risk perception was not a decisive factor. So people with high risk perception would also not necessarily follow the protective measures because there were other factors influencing their decisions, like the attitudes and the risk perception of the family or the norm within the community. So understanding those factors is absolutely critical to know where to make the investment and not to waste our resources and time. It's similar with routine immunization very often, and vaccination in general. For example, in Kosovo, a lot of people are not getting the vaccine because the registration system was overcomplicated. They had to go online to register themselves, and a lot of vulnerable groups, Roma communities, found it extremely difficult. They didn't have access to internet, so it wasn't that they had low risk perception. It was just the other barriers preventing them from taking the decision to take the vaccine. And with routine immunization, we hear from caregivers very often that it's either the services are not designed the way they would prefer them to be. For example, they have to wait in long lines along with other children or adults who are sick and coming for different medical services. So again, risk perception might be in some cases a decisive factor, but not in others. And understanding those factors is absolutely critical before making the investment in a solution. Thank you, Ken.
All right, thanks, Sergio. So yeah, we have a few minutes before we close. Rula, would you like to come in?
Yes, thank you for giving me the chance to ask. I work in a Jordan Breast Cancer Program, actually to improve the SDG and accessibility to health by everyone. We worked on breast cancer screening, but our main focus when we started was on people. We raised their awareness and we have made great behavioral changes in a way that breast health is not a taboo anymore. However, we worked on availability of the services. However, when we dig deeper in, we discovered that the problem is in the system and the accessibility of health. The service providers are not accountable for the service that they really should provide. The referral policy that they are adopting or making up in some places hinders the screening process. So I'd like to ask, what were the behavioral nudges that targeted healthcare providers or service providers, whether it's on the bottom up level or decision makers level, to make them more accountable and to adopt to support the target that you want to do. And when it comes to system, can the human-centered approach make a difference, especially that those who are responsible for the system are people with their own beliefs, or they're not they don't consider screening as a priority, especially when it comes to NCDs or especially cancer. Thank you. Over.
All right, thanks, Rula. Sergio or Nino, would you like to answer that in the next minute?
Oh, I can try. I mean, I will make just a parallel. The individual's accountability is very important, and not everything can be addressed or solved through behavioral insights. In this region, in Europe and Central Asia, we do have quite an extensive program on training program for health professionals on interpersonal communication for immunization to try to address their individual bias towards some populations or some practices. And to strengthen their self-efficacy, to engage with people and communicate on what is important to them, give them space for asking questions, so that the services that are provided are tailored to their needs. So this individual accountability is, through training, is a way of doing it. But of course, that will not solve everything. We also have to look at the job descriptions. We have to look at the performance monitoring aspects and things like this. But I will conclude with an example from North Macedonia. which I mentioned in my 5 minutes at the beginning of or in the middle of the call. We worked using the human-centered design approach to look at the uptake of the MMR vaccines. And working with the health professionals and the caregivers, we really understood that people sometimes, there are a lot of myths, misinformation around the MMR vaccines, and caregivers don't have the courage to ask questions. And the health professionals sometimes think, well, it's not important, probably everybody knows, so they don't dare to give space for people to engage in this type of conversation. So we designed with them some type of reminders. It's some notes on the desk of the health professional. So when the caregiver enters, they see it and they are encouraged to ask a question about the vaccines. And the health professional sees it itself, ask the caregiver if they have any question about the vaccines, and we posted posters. And it's something that will be tested at a large scale in North Macedonia. So again, it's a way of kind of influencing and increasing the accountability of the professionals through these type of interventions and human-centered design approaches. Thank you. And I don't know, Ben, maybe you have some more ideas on that.
No, thanks, Sergio. I think we need to wrap our webinar. So I'll hand it back to Ken.
All right. Thanks to all. I've already posted in the chat box for joining this session and for your insightful questions and comments. And we thank the organizers of this United Nations Behavioral Science Week for this opportunity. And this is just the start or continuation of the journey. I'm sure there'll be another opportunity to share our insights again. Thank you so much and enjoy the rest of your day or night. Thanks.